Hi everyone, I am Dr. Himadri. Let's talk about chest X-ray today. So, in the chest X-ray, there are few techniques which are commonly used and these are universal. This is termed as standard techniques. Okay. So here you can see the person is standing and the X-ray beam is coming from behind. This is called as PA view or posterior interior view. That is, the rays are coming from posterior side. Okay. Secondly, it should be done in a erect posture. The person should be standing and it should be done in a suspended end inspiration. That is, the person will take deep inspiration and also hold it, and during holding this breath, the X-ray beam, the X-ray beam should be there. We should give the X-ray beam. Okay, so this is called a suspended end inspiration. This is done routinely, but still in expiration it could be done. There are few cases, few exceptions where we do X-ray in expiration. Okay, in expiration there will be crowding of the blood vessels. Okay, because in inspiration, as there is more amount of air, there is no crowding, but in expiration there is crowding. It is done in usually few conditions, but two conditions are important: pneumothorax and foreign body aspiration. So the chest X-ray is done in expiration, in foreign body aspiration, as well as in pneumothorax. Because in expiration the lung volume decreases, and as there is decrease in the lung volume, in few conditions we can have better visibility of the pathology. Okay, let's talk about the basic difference between the PA view and the AP view in chest X-ray. So in PA view the rays are coming from back. In AP view, usually what happens in ICU setup where the child or the patient is very sick, in those setup the AP view is done. Rays are coming from up. So in PA view and AP view there are few differences that you can find in chest X-ray. In PA view, the clavicle will be present within the lung field, but in AP view you can see the clavicles are present above the lung field. It is present above the lung field. And secondly, there is false cardiomegaly which is seen in antero-posterior view. If you forget everything in the exam, please remember these 2 points. There are a few other points like scapula are seen in the periphery in case of PA view, and you can read from here. Okay, please don't forget these 2 things. Let's say you are in an exam and your professor is asking about the normal chest X-ray asking about a X-ray interpretation. You have to define the X-ray in few points. Number 1, if there is centering or not. In the spinous process of the vertebra, you have to draw a line. Okay, and from it, the medial end of the clavicles bilaterally in the left and the right clavicles, if it is equal, the distance is equal, it is called as proper centering. Number 2, is there any appropriate exposure present or not? How to look at it? The lower thoracic vertebra, if the lower border of the lower thoracic vertebra is just visible, we call it appropriate exposuring is done. If appropriate exposure is not there, the film will be either black or too much white. You cannot understand the pathology what is present in it. Okay, so the margins of the lower thoracic vertebra should be just visible. And number 3, what you should look for? The rib identification. This is very, very important. How these are identified? Look, the straight portions, as the rays are from posterior side, the straight portions will be, straight portion will be the posterior margin of the ribs. Okay, the curved one here you can see, these are anterior end of the rib. Okay, and ideally 6 anterior ribs and 10 posterior end of the ribs should be visible. If it is more than 6 in case of anterior and more than 10 in case of posterior ribs, we call it hyperinflation of the lung. In children, we can see in few conditions like acute bronchiolitis or maybe viral pneumonia like this. Okay. Number 4, what you have to look for is the mediastinal margin. Mediastinal margin means here the hard border, because this is what basically defines the silhouette or the margin. Okay, here you can see I am drawing the SVC, and this is the RA, that is the right atrium, and this portion IVC, which is this border. And now you can see what I am drawing is the aortic knuckle. Okay, this is aortic knuckle, and this is called as your main pulmonary trunk or main pulmonary artery. Okay, now the green one is here LA appendage or the left atrial appendage, and this yellow portion is LV, that is left ventricle. So these borders are very important in understanding different pathologies. From here you can have an idea about the silhouette. Okay. After understanding the silhouette, you need to talk about, or you need to look at the, is there any cardiomegaly present or not. Okay. How we actually look for cardiomegaly? This is the fifth point. You can see how we actually look for the cardiomegaly. In the vertebra, there are spinous process. Please draw an imaginary line in the spinous process, and from it, A is representing the maximum portion of the heart, which is present in the right side, B in the left side, and C is here the maximum, the thoracic diameter. Okay, so what it is? A plus B by C. If it is more than 0.55, it is called as cardiomegaly. More than 0.60, it is also called cardiomegaly, but more than 0.60 for infant, more than 0.55 for older children, we call it cardiomegaly. Then the sixth point is CP angle. You must look at the CP angle. Here you can see in the photo what I have drawn. This is the right CP angle and the left CP angle. CP means costophrenic angle. Costo means ribs, and also the phrenic means diaphragm. Okay, so before understanding the different pathology which you can find in the lung, we must know what are the differential radiographic density theory. Number one is the air density. Air means totally black, and number two here is the subcutaneous tissue, the fat which you can see. It is present in the axillary region. You can see what I have drawn. Number three is the water density or the soft tissue. It looks like that is present in the heart, in the liver region. Number four is the bone. You can understand the bone, and after that still we have another density which is even denser than bone, that is the metal density, because nowadays there are multiple orthopedic implants which are done. Therefore these 5 densities you can define or you can understand. So look, this is the lung pathologies we are going to discuss. So what is pleural effusion? Pleural effusion means collection of fluid within the pleural cavity or within the pleural space, that is the visceral pleura and the parietal pleura. There is a space, we call it. So if there is collection of fluid within this space, we call it pleural effusion. Here you can see in the lung, the posterior CP angle is much more deeper than the anteriorly placed angle. Okay, so at first there will be, due to gravity, the fluid will go in the posterior CP angle, then will eventually come to the anterior CP angle, costophrenic angle, then there will be obliteration of the anterior CP angle. Okay, so what is the investigation of choice for pleural effusion? Please remember one thing: fluid is the friend of USC. The F word. Fluid is the friend of USC. Okay, so the still we can do chest X-ray and can find it, but in USC is the investigation of choice in case of fluid collection within the spaces and the multiple regions in the body as well. There is obliteration of CP angle that you can see in the right side. Okay, but in the left side the CP angle is normal. So in this, what happens if the disease further progresses after obliterating both the angles? If it eventually goes up and up, the fluid goes up and up, it eventually forms like a meniscus. You can see it's like a meniscus. So this is called as pleural meniscus sign. Pleural meniscus sign is seen in pleural effusion when the fluid is further increasing. Let's say the fluid increases much so that the total spaces being covered. If there is too much of fluid like that, what it will do? It will push the mediastinum to the opposite side. Okay, it's basically pushing the mediastinum to the opposite side. So this is massive pleural effusion. Okay, with the shifting of the mediastinum to the opposite side. Here you can I will show you a photo. Look at this photo. What happens in the left side? There is too much of fluid, that is pleural effusion, massive pleural effusion, which is pushing the mediastinum to the opposite side. Massive left-sided pleural effusion with mediastinal shifting towards the opposite side. So I talked earlier that the USC is the investigation of choice in pleural effusion. Here you can see what I have drawing here. That is the visceral layer of the pleura, and this is the parietal layer of the pleura. In between the visceral layer and the parietal layer of the pleura, this is the black space that you can see. This black region is basically the fluid, that is the pleural effusion. This is the HRCT, that is high resolution CT of the thorax. What you can see from here is that this is the mediastinal window, what I am drawing right now. So this is the pleural effusion. In the right side there is a pleural effusion and this is the lung window. Here you can also see that there is a pleural effusion. So look at this image, what it is. The person actually the child is standing here, but still you can see the white portion. It's not like the pleural effusion that I have drawn earlier. Okay, so this is basically empyema, because there is collection of pus. This is semi-solid, and in between septa there is the fluid which is present. Therefore the person may be supine or may be standing. In the standing position there is gravity is present, but still the fluid is not going downwards. So this is empyema. There is collection of pus within the pleural space, and due to this there is a separation in between the parietal pleura and the visceral pleura. Please look at this HRCT thorax. In the empyema, what happens? The visceral pleura and the parietal pleura. Look at the enhancement, the white color enhancement of the visceral pleura and the parietal pleura. This is called as split pleura sign. This is because of what? This is because of the pus which is present, that leads to pleural enhancement. Okay. So this is another HRCT you can see. So the first photo, this is pleural effusion. Because of gravity it is going down, but in empyema, look, this is not totally going down because so the second photo was empyema. So now talk about pneumothorax. Okay, what will be the investigation of choice in case of pneumothorax? Yes, fluid is the friend of ultrasound, which I talked earlier, but remember air is the enemy of USG. So what will be the investigation of choice in case of pneumothorax? Yes, please guess. It is going to be your CT, that is CT scan of the thorax. We can also do chest X-ray, we can also do USG, but the investigation of choice here is CT scan. Okay, CT of the thorax. So what we can find in the chest X-ray of the pneumothorax patient? Let's go step by step. There are 4 to 5 signs that you can see in pneumothorax. Number 1, this is the visceral layer of the pleura. What is pneumothorax? In between visceral layer and the parietal layer there is presence of air. Okay, so here you can see the visceral pleura line. Number 1, visceral pleura line. And number 2, what you can see is that there is more lucency. This is called as hyperlucency, more blackness with absent bronchovascular markings in the right side. So this is very important, hyperlucency with absent bronchovascular marking. So this is not the lung tissue. Okay, and number 3, you can see the deep sulcus sign. Deep sulcus, that is anterior CP, that is the CP angle. In the right CP angle you can see this is become much more deep. This is called deep sulcus sign. And number 4, what you can see from here is that if it is massive, that is a tension pneumothorax, your mediastinum will be shifted to the opposite side. Okay, this is called as mediastinal shifting. And also you can see the widening of the rib cages. In the left side the ribs are normal, but in the right side in the pneumothorax, because of air pressure, there is widening of the rib cages. Okay, so this is another neonate which came in our hospital. The child was intubated from outside, and we know what they actually did. There is, you can see there is a right sided pneumothorax, and this is basically we can call it tension pneumothorax probably, because there is mediastinal shifting to the opposite side with hyperlucency and the visceral line which you can see. Look at this is definite tension pneumothorax, because your left sided, you can see left sided pneumothorax which is pushing the mediastinum to the opposite side. Okay, So that is tension pneumothorax. This is also pneumothorax CT scan. So now let's guess what is the normal USG. This is basically USG of the lung, what is normal and what is abnormal. The first one, A, that is the normal lung. What you can see, the ribs, and underneath the ribs there is tissue, and after that there is visceral layer and the parietal layer of the pleura, and just beneath it you have lung tissue. So these are representing waves, the ribs and the pleura representing the waves, and the sands are your lung tissue. So this is called a seashore sign. It looks like a seashore look. So this is the normal lung, what we can find in USC. But in pneumothorax, what you can find? You can find barcode sign. Okay, so you can very well see there is barcode sign. And another thing is that the normal movement of the lung will be restricted there. So now let's talk about the chest X-ray part, and we wanna talk it in a little detail. In chest X-ray, please remember, according to differential radiographic density theory, you can have the fluid will appear as white. Okay. In the lung, please see what happens in this case. There is bilateral patchy white opacifications that you can see. These are due to interstitial inflammation, okay, as well as fluid collection. This typically happens in viral pneumonia. Bilateral diffuse fluffy opacifications which are present, as well as you can see that there is the dome of the diaphragm becomes flattened. And goes down, and also 7 to 8 ribs you can count. So therefore there is bilateral hyperinflation of the lung field. Bilateral hyperinflation, that is air trapping is happening. Okay, as well as there you can see the perihilar region, there is peribronchial cuffing, as well as white straight lines. These are reticular pattern. So these 3-4 things is a characteristic of viral pneumonia. Okay, bilateral diffuse fluffy opacification, as well as bilateral hyperinflated lung field with perihilar peribronchial cuffing along with reticular pattern. You can see in the viral pneumonia, bilateral lung is involved, but in case of bacterial pneumonia, a single lobe is usually involved. Okay, so the same patient, within 24 to 48 hours, the patient deteriorated. Why? You can see there is right upper lobe collapse consolidation. So the secondary bacterial infection is usually present in 30 to 45% cases of the viral pneumonia. Please note it. In viral pneumonia, there may be bacterial pneumonia superadded in 30 to 45% of cases, and the patient will deteriorate. Okay. Now let's say the bacterial pneumonia. What you will find in case of bacterial pneumonia? To understand it, you need to know what is silhouette. Silhouette means the shadow. Okay. Suppose now what I am drawing, the portion of the heart, if you cannot make this portion, that is if it is total becomes white and the boundary cannot be made out, this is due to right upper lobe consolidation. Please remember it, because right upper lobe is anatomically present in that part. Okay, if it is right middle lobe and you are drawing the right lower lobe, if it is right middle lobe consolidation, the right border of the heart you cannot define it. Okay, there will be opacification and it will obscure the right border of the heart. If it is right lower lobe consolidation, the right dome of diaphragm cannot be made out. There will be white opacification involving this part. Okay, now this is the oblique fissure of the left lung, and above it there is left upper lobe, below it there is left lower lobe, and this is the lingular segment of left lung. Now let's say there is opacification which obscured the left border of the heart. What it is? This is due to left upper lobe consolidation and mostly lingular segment of the left upper lobe which is getting involved. And if the left dome of the diaphragm you cannot made out, if it is widely opacified, this is due to left lower lobe consolidation. Please remember this picture, because that is how you will be able to differentiate the different lobes, which lobe is basically involved. Okay, now in this photo you can see right upper lobe consolidation. Please see, you cannot make this upper portion. Okay, in this photo please see, can you make the right border of the heart? No, Therefore this is right middle lobe consolidation. Okay, you can see the seal hood, right border of the heart you cannot make it. And in this photo what you cannot make, please see, in the upper portion you can easily differentiate, as well as please see that the right border of the heart you can easily differentiate, because there is there's a black line which is going, that is air is going, but what you cannot make is the right dome of diaphragm, therefore right lower lobe consolidation. In this photo please see the left lobe, the left border of the heart you can't make out, therefore what it is, this is probably a lingular segment of left upper lobe consolidation. Okay, in this photo can you make the left border of the heart? Yes, obvious, but left dome of the diaphragm you cannot make it properly, therefore this is what it is, left lobe, left lower lobe consolidation. Okay, in this patient what you can see, there is left sided whiteout lung. What could be the differential diagnosis for left sided whiteout lung? It could be pleural effusion, it could be collapse, or it could be consolidation. So can you differentiate from this picture? In all these three conditions there will be left sided or there will be unilateral whiteout lung. Okay, so how to differentiate? In case of pleural effusion, look, in case of pleural effusion, as there is collection of fluid in the pleural space, there will be mass effect, and also the mediastinum will be shifted to the opposite side. Okay, the mediastinum, that is the, please look at the trachea, it will be shifted towards the opposite side of the whiteout lung. But in case of collapse, it will draw or it will drag the mediastinum towards its side. Therefore, there will be pulling of the mediastinum towards the same side in case of collapse. But in case of consolidation, the trachea would be in the midline. There will be no shifting. Along with, you will get air bronchogram sign. Okay. Now let's see in this picture what you can see. Look, there is whiteout lung in the left side, but the mediastinum being shifted towards the right side. What that means? There is left-sided massive pleural effusion. Okay. Okay. Now let's talk about lobar collapse. What is lobar collapse? This is horizontal fissure. You must have some anatomical ideas, like this is horizontal, this is oblique fissure, and there is right upper lobe, middle lobe, lower lobe, and left upper lobe, left lower lobe, which are divided by a oblique fissure only. Okay. In the left side there is only one fissure. So please see from here, if the horizontal, if there is collapse of the right upper lobe, the horizontal fissure will go up. It will cause a curve like, okay. And if there is a right middle lobe collapses, it will form a triangular sepet in the right heart of the right border of the heart, like that. So this is what, this is your right upper lobe collapse, where the horizontal fissure goes up. This is right middle lobe collapse, it looks like a triangular region. This is right lower lobe collapse. In right lower lobe collapse, it looks like a triangle, okay, in the lower region. So what it is, you can see in the photo, this is very obvious. This is left upper lobe collapse. When left upper lobe collapses, it goes upward, as well as there is compensatory hyperinflation of the left lower lobe of the lung that will cast a shadow, that will go because of this air, the knuckle region, aortic knuckle region, you can see there is a hyperlucency around the aortic knuckle region. Okay. Initially, because the left upper lobe goes up, it forms like a curtain or veil like opacity, and secondarily, because of hyperinflation of the left lower lobe of the lung, there is compensatory hyperinflation that will cast a shadow around the aortic knuckle. There is lucency around the aortic knuckle. This is called as looped Cecil sign. It is seen in left upper lobe collapse. In left lower lobe collapse, what you can find? Once again, the triangle. Okay. Now let's see bronchiolitis, acute bronchiolitis, very important condition in children. Usually in 2 months to 2 years of children, there is acute bronchiolitis. Most common cause is RSV, that is respiratory syncytial virus. So here I am drawing the right side, there is a normal lung, let's say, and the left side I will draw the pathological, that is acute bronchiolitis. Actually it happens bilaterally, but basically to let you understand this. What happens, there is viral infection which is causing upper respiratory infection via respiratory epithelium it goes down. What happens? Look in the left side, in the what there is inflammation of the bronchioles, inflammation of the bronchioles. Okay, the red dots basically represents that. Here what I am drawing is that the airway during inspiration and during expiration, this is the normal airway what I am drawing. Right now what I am drawing is pathological airway. In inspiration you can see there is inflamed bronchioles, but in expiration you can see the lumen becomes too much narrowed that even you cannot appreciate it. This is seen in acute bronchiolitis. In inspiration there is, as it is inflamed, the lumen is narrow, but in expiration it is further narrowed. Okay, so therefore there is, in inspiration air will go in, but in expiration it will not be able to come more properly. That will lead to air trapping. This is called, and that will eventually lead to hyperinflation, bilateral hyperinflation of the lung. During expiration it is not able to come, all the airs are not able to come. How you will find it in the X-ray? Let's see. I talked earlier that 6 anterior ribs, if it is present, this is normal. If more than 6, this is hyperinflation. Here 7 to 8 you can see. So this is bilateral hyperinflation, which is seen in acute bronchiolitis. This is very important. Okay, and another thing you can see is that there is perihilar region. What happens? This is called as perihilar coughing due to bronchiolar inflammation, the narrow bronchioles getting inflamed. Okay, now let's see the another thing, that is croup, very important in children. It is also called as acute laryngotracheobronchitis. What happens? Please remember one thing. In children, the narrowest portion of the airway is the subglottic space or the subglottic region. If the subglottic region, here you can see I am drawing the subglottic portion, if it is the narrowest, what happens? There is inflammation of this portion, so this portion becomes further narrowed. This becomes further narrowed. If it is further narrowed, what it will look like? The upper portion of the charge, the tip of the charge, like that. This is called a stipple. So in X-ray, you know, there are some artistic doctors, they probably named it the stipple sign. Okay, this is seen in croup, that is acute laryngotracheobronchitis. So if you are still watching me, probably you could have understood multiple things as whatever. Please consider subscribing and sharing with your friends. Okay, thank you.